Hello and welcome to Doc.AT. In today's video, we're diving into the critical topic of obstructive shock. What it is, why it happens, its pathophysiology, and how to respond effectively. Let's break it down together. Obstructive shock is a life-threatening condition where mechanical obstruction to the flow of blood prevents the heart from effectively pumping, leading to inadequate tissue perfusion and oxygen delivery. Now, let's look at the pathophysiology. The hallmark of obstructive shock is impaired cardiac output due to an external or internal barrier. This results in decreased preload or filling of the heart. Conditions like cardiac tamponade or tension pneumothorax restrict the heart's ability to expand and fill during diastole. Increased afterload. Conditions like pulmonary embolism increase the resistance the heart must pump against, particularly affecting the right ventricle. Reduced effective stroke volume. The heart's pumping efficiency is compromised, reducing systemic oxygen delivery. Now, let's discuss the causes of obstructive shock. Cardiac tamponade. Mechanism. Pericardial effusion builds up and compresses the heart, preventing proper diastolic filling. Causes: trauma, pericarditis, malignancy, uremia, or post-cardiac surgery. Pulmonary embolism. Mechanism. A large clot blocks pulmonary blood flow, increasing pulmonary vascular resistance and causing right ventricular failure. Risk factors: immobility, deep vein thrombosis, surgery, malignancy, or hypercoagulable states. Tension pneumothorax. Mechanism: air accumulation in the pleural cavity compresses the lungs and mediastinum, reducing venous return to the heart. Causes: trauma, mechanical ventilation, or underlying lung disease. Aortic dissection. Mechanism: blood enters a tear in the aortic wall, creating a false lumen that compromises flow to major arteries and potentially obstructs cardiac output. Risk factors: hypertension, Marfan syndrome, and Ehlers-Danlos syndrome. Severe valvular disease. Mechanism: obstructed blood flow through stenotic valves, such as the aortic or mitral, hinders cardiac output. Intracardiac obstruction. Tumors such as atrial myxoma or thrombi blocking intracardiac blood flow. Now that we've covered the causes, let's move on to the clinical presentation. Clinical presentation includes vital signs: hypotension with systolic blood pressure less than 90 millimeters of mercury and tachycardia as a compensatory mechanism. General symptoms: fatigue, dizziness, confusion, or altered mental status. Oliguria or low urine output. Physical examination findings can vary based on the underlying cause. Cardiac tamponade. Beck's triad, which includes hypotension, distended neck veins, and muffled heart sounds. Pulsus paradoxus. A drop in systolic blood pressure greater than 10 millimeters of mercury during inspiration. Pulmonary embolism. Tachypnea, pleuritic chest pain, hemoptysis, and cyanosis. Signs of deep vein thrombosis, such as a swollen, painful leg. Tension pneumothorax. Unilateral absent breath sounds. Tracheal deviation to the opposite side. Hyperresonance on percussion. Aortic dissection. Sudden, severe, tearing chest or back pain. Differential blood pressure between arms. A new diastolic murmur, such as aortic regurgitation. Valvular disease. Loud systolic murmur in stenosis. Signs of congestive heart failure, such as pulmonary edema. To confirm the diagnosis, several investigations are performed. These include bedside tools such as point-of-care ultrasound to quickly assess for tamponade, pneumothorax, or right ventricular strain. Electrocardiogram or ECG, findings like right heart strain, with S1Q3T3 in pulmonary embolism, or low-voltage QRS and electrical alternans in tamponade. Laboratory tests, including elevated D-dimer in pulmonary embolism, troponin to indicate myocardial strain, and arterial blood gas showing hypoxemia or respiratory alkalosis. Imaging. Chest X-ray. Enlarged cardiac silhouette in tamponade. Pneumothorax visible. CT angiography. Gold standard for pulmonary embolism or aortic dissection. Echocardiography. Essential for identifying cardiac tamponade, right ventricle dilation, or valvular abnormalities. Next, let's discuss management strategies for obstructive shock. Management involves 1. Immediate resuscitation, which includes securing airway and breathing. ensuring oxygenation and ventilation, mechanical ventilation if necessary. Circulation, administering IV fluids cautiously. Vasopressors, like norepinephrine, may be used for persistent hypotension. 2. Definitive treatment tailored to the cause. Cardiac tamponade, pericardiocentesis or surgical drainage. Pulmonary embolism, anticoagulation with heparin or thrombolytics, or surgical embolectomy for massive pulmonary embolism. Tension pneumothorax, immediate needle decompression at the second intercostal space, followed by chest tube placement. Aortic dissection, type A requires emergent surgery, while type B is managed medically unless complications arise. Valvular obstruction, valve replacement or balloon valvuloplasty in severe cases. Prognosis, without timely intervention, mortality is extremely high. However, prognosis improves significantly with rapid identification and treatment of the underlying cause. Long-term outcomes depend on the reversibility of the primary condition and prevention of recurrence. Thank you for learning with us today. If you found this helpful, don't forget to like, share, and subscribe for more educational videos.